Welcome dear students, this is Dr. Pratyusha and we are learning about the disorders of external auditory canal. And there are 4 types as we have repeatedly learnt. First is congenital, second is inflammatory, third is miscellaneous and finally neoplastic. We have already learnt congenital and inflammatory, and in this video let us learn about miscellaneous conditions affecting the external auditory canal. And the first one in this category is impacted wax. Cerumen. In colloquial language, it is called wax. So let us now understand what is cerumen exactly. It is composed of secretions of sebaceous glands, ceruminous glands. What are ceruminous glands, by the way? They are modified apocrine sweat glands. Apocrine in the sense a part of the cell is pinched off along with the secretion. So they are modified apocrine sweat glands. So secretions of sebaceous glands, ceruminous glands, epithelial debris, desquamated, epithelial debris, keratin, hair, and finally dirt. All these together constitute cerumen. Secretions of sebaceous glands, ceruminous glands, desquamated epithelial debris, keratin, hair and dirt together form cerumen. So now what is each one secreting? Sebaceous gland secretions are rich in fatty acids. They are rich in fatty acids. Ceruminous gland secretions are rich in lipids and pigment granules. Desquamated epithelial debris. Where is that coming from? The tympanic membrane sheds off desquamated epithelium and also keratin. These two the combined secretion of these glands mixes with the desquamated epithelial cells and also the keratin that is being shed from the tympanic membrane and also from the deep bony meatus. They all combine and form wax. These two are from the tympanic membrane and the deep bony meatus. Hair is of course present and dirt is coming from the external environment. All of them are together forming cerumen or wax. Now what is this cerumen? By now you must have understood that it is absolutely physiological. It is not some pathological condition. So what is the function of this cerumen? It has a protective function. It entraps any foreign material that enters the external auditory canal. First one, entraps the foreign substances. Next, it has an acidic pH that is bacteriostatic and fungistatic in nature. It maintains an acidic pH which is bacteriostatic and fungistatic. Correlation with diffuse otitis externa. We have seen that diffuse otitis externa is more common in summer seasons when there is more sweating, where this acidic pH is converted into alkaline pH, and that is responsible for bacterial invasion. So naturally and normally the pH of the external auditory canal is acidic because of cerumen, and this acidic pH is bacteriostatic and fungistatic. Apart from that, it also lubricates the external auditory canal. These are the three functions of cerumen. Now, until here there is no problem, but if this cerumen gets impacted inside, if it is not being shed off periodically, that causes problems. So first let us understand why does it get impacted there. What is the cause for wax collection? Let us see what are the causes of excessive wax collection. Logically thinking, first possible cause could be excessive secretion. If much more than what is needed is being secreted, obviously it cannot be expelled so easily and it starts getting accumulated there. That is one cause. Second is excessive desquamated epithelial tissue from the canal wall. And the third cause is less oily secretions from sebaceous glands, making it dry. And when it is dry, it is also hard and it is difficult to get expelled. That is another cause. Or presence of stiff hair that is not allowing the wax to come out, or presence of narrow or tortuous external auditory canal, then also it becomes difficult. Another possibility is any obstruction in the external auditory canal. That also does not allow the expulsion of cerumen, and hence it gets impacted inside. Now these are the causes. Okay, it has impacted. So what? Let us see what are the consequences of this impaction. For whatever reasons, these are the main causes. Apart from that, even living in hot and dry climate and some occupations such as mining and apprehensive patients, they all also are predisposed to having excessive wax collection. But these are the main causes that I have written. Because of all these causes, wax is collected, and what does it cause? The patient experiences a sense of blocked ear. It is one of the most common complaints in an ENT OPD, where the patient comes and says that he has a sensation of a blocked ear. His or her ears are blocked, and because of that even the hearing is affected. That is because of this impacted wax. Hearing loss. Hearing is affected. I can't say it's completely lost obviously, but there is some disturbance in sound hearing. Itching is seen. All this impacted wax will cause itching. Another thing that happens is, now this wax that is accumulated is usually hard and dry, and suppose for any reason water has entered the external auditory canal, either the patient is swimming or during bathing or head bath generally, some amount of water goes inside, and this water will cause the wax to swell. And this sudden swelling up of the wax will increase all these symptoms. There is more amount of hearing loss. It's like an acute exacerbation of everything. Okay. So sudden exacerbation of symptoms upon entry of water into the external auditory canal. Next, if at all this impacted wax is rubbing against the tympanic membrane, that will lead to tinnitus and giddiness also. Ringing sensation in the ear and giddiness. If it is in contact with tympanic membrane. Now we know that the external auditory canal is supplied by auricular branch of vagus nerve. Yes, the posterior aspect. And that is responsible for the cough impulse sometimes when the ear is being scratched or some instrumentation is going on in the ear. Similarly, the presence of this impacted wax, excessive wax, can sometimes stimulate the cough reflex. Cough reflex can occur. Next, the impacted wax can also ulcerate the meatal skin and it can result in a granuloma formation. It can ulcerate the meatal skin and result in granuloma formation. These are all the problems with impacted wax. It can make the patient feel having a blocked sensation in the ear, and it can cause hearing loss, it can cause itching, and whenever water enters, there is exacerbation of symptoms, and if it is touching the tympanic membrane, it can cause tinnitus and giddiness. Cough reflex can be activated, and a long-standing impacted wax can also ulcerate the meatal skin and cause granulomas in the external auditory canal. Now we have understood that normal wax is physiological and protective, but an impacted wax is pathological. It can cause problems, so obviously we have to treat it. How do we treat it? Remove the wax. But it is not as simple as that. There are certain things that have to be borne in mind. One is, if the wax is soft, it can be easily expelled out. Soft wax is good for the doctor. They can simply do syringing. Syringing can be done where water is taken at room temperature and some povidone iodine is added to that, a few drops, and the needle is positioned now this is important, the needle is positioned in posterior-superior direction. And water is injected to push the wax out. In case it is completely occluding the external auditory canal, first a little space is created on the posterior aspect and then the water is pushed with mild force and finally everything comes out. So I have a picture of syringing. This is how it looks. All the soft wax is there inside the external auditory canal and this is the syringe. In a posterior superior direction, water along with some 5% popped in iodine drops is injected and all this wax will then be expelled. Now as in this case, when it is completely occluded, a small room is made on the posterior aspect and then water is pushed in. This is all very simple if the wax is soft. But if at all the wax is hard, then what to do? Hard wax needs to be softened or broken down first, and for that we use cerumenolytic agents. Cerumenolytic, breaking the cerumen. What are some cerumenolytic agents? Glycerin, hydrogen peroxide, olive oil, sodium bicarbonate, and acetone. It's a big list. There are many agents that can work as cerumenolytic and there are so many commercial preparations in the market also that serve as cerumenolytic agents. So first we use the cerumenolytic on the patient for a week, for 5 to 7 days, and then the wax will slowly soften and then we can remove it by syringing or suctioning. They break the components of wax so that it can be easily expelled. Apart from syringing, other techniques are also used for wax removal. They are, wax can be removed by a cerumen hook. Just like how foreign bodies are removed, even wax is removed with a hook, or even blunt curettes or some scoops such as Jobson horn probe. They can all be used for removing firm wax after it has been softened. Instrumentation that is done for wax removal has to be very skilled and it has to be carefully done. Otherwise, during trauma in external auditory canal, we have learned that apart from what the patient does, such as putting various objects into the external auditory canal, even unskilled instrumentation by the doctor can result in trauma to external auditory canal, and then the entire sequence of otitis externa occurs. So instrumentation has to be very skilled and it has to be done carefully under monitoring by a senior doctor if at all you are learning initially, and it has to be gently performed to avoid any lacerations and injuries to the external auditory canal and to prevent complications and secondary infections. Now another possibility, dreaded possibility is if it is very harsh, it can go and even perforate the tympanic membrane. So instrumentation should always be done gently. Let me write the other methods for you. Cerumen hook, Jobson horn probe, a blunt curette. All these can be used. I have another picture. Now here a hook is being used and we put the hook and draw out all the wax. This can be used for a moderately firm wax or even it can be softened and then used. Before we hook, a small tunnel is created again in the posterior superior part only. All removal of wax procedures are done in posterior superior direction. First, the auricle is pulled upwards and backwards, and then the external auditory canal is straightened, and then in a posterior superior direction, either syringing or suctioning, anything is performed. Now, precautions that have to be taken before syringing are, because we are injecting water, we have to make sure that the water is in room temperature, otherwise it will activate the vestibular response and cause giddiness in the patient. And second precaution that has to be taken is syringing should not be performed if at all the patient has tympanic membrane perforation. Otherwise, all this water along with the debris, dirt, everything will go into the middle ear and cause otitis media. So, do not perform syringing in patients with tympanic membrane perforation. So, contraindications for syringing are any history of ear surgery, history of tympanic membrane perforation, or even when the external auditory canal is inflamed, acute inflammation is there. Even in those circumstances, please avoid syringing. And what are the complications that can occur as a part of wax removal? Because it is instrumentation, always complications are possible. One, as I told you, is rupture of the tympanic membrane. Okay, let me write down the complications. One is rupture of tympanic membrane. Second is it can lead to vertigo. The procedure can cause vertigo in the patient. And if at all the patient is having otitis media, it can get reactivated, reactivation of quiescent otitis media. These are some of the complications that can occur because of syringing, so kindly be mindful of them. This is all about impacted ear wax. Let me quickly summarize. Cerumen is composed of the secretions of sebaceous glands which are rich in fatty acids, ceruminous gland secretions which are rich in lipids and pigment granules, desquamated epithelial debris and keratin from tympanic membrane and deep bony meatus, hair and dirt, all of them together constitute cerumen. And the functions of cerumen are to entrap the foreign substances, and it has an acidic pH which is bacteriostatic and fungistatic, and also cerumen lubricates external auditory canal. It can get impacted inside the external auditory canal if there is excessive secretion of cerumen or excessive excessive formation of desquamated epithelial cells, or if there is any obstruction in the external auditory canal, or the canal is narrow and tortuous, or less oily secretions from sebaceous glands that will make it hard and firm and difficult to be expelled. Dry wax is formed, or presence of stiff hairs in the external auditory canal can also prevent expulsion of wax. And because of all this, it gets collected, and this collected wax will cause clinical features such as blocked ear, hearing loss, tinnitus and giddiness if it is touching the tympanic membrane, and sudden exacerbation of symptoms will occur when water enters into the external auditory canal, because that will cause swelling up of this wax and increases the symptoms. And it can activate the cough reflex due to the auricular branch of vagus nerve, also called as Arnold's nerve. And finally, long-standing impacted wax can ulcerate the meatal skin and result in granuloma. So we have to treat it by removing the wax, as simple as that. But how to remove? If it is soft wax, syringing can be done. If the patient has no perforated tympanic membrane, and also the patient has no history of any previous ear surgery or no active acute inflammation of the ear. Under these conditions, syringing can be done, and it should be done with water of room temperature. Hot or cold water will cause giddiness and vertigo-like symptoms. So room temperature water with a few drops of 5% povidone iodine can be used for suctioning in a posterior-superior direction. If the wax is hard, we can initially use cerumenolytic agents and for 5 to 7 days that will make the wax soft. And then these procedures can be done. Apart from syringing, if at all syringing is contraindicated for the above mentioned reasons, then we can use a cerumen hook or a Jobson horn probe or a blunt curette to remove the wax. Complications involved in this procedure are rupture of tympanic membrane, any trauma to the external auditory canal such as lacerations or any other injury can occur, vertigo can occur, and reactivation of quiescent otitis media. This is all about impacted wax. Now, let us look into the next miscellaneous condition, that is foreign body in the ear. The next miscellaneous condition is foreign body in the external auditory canal. Foreign body. And foreign bodies can be classified into two types: non-living substances and living substances. First, let us look into non-living. Generally, the moment we think of foreign body in the external auditory canal, what comes into our mind is pediatric patients, because there is an age group usually until less than 5 years, but they have a habit of putting various things into various natural orifices in the body, sometimes into the mouth, sometimes into the nose, and sometimes into the ear. They put various types of objects, whatever is found. But it is also seen in adults sometimes, due to, as I said earlier, all these habits such as picking the ear with matchsticks, cotton swabs, Q-tips, and sometimes they can break off and those pieces can be left inside. So that is how it happens in adults. Let us look into what are the substances that are seen. Non-living substances can be of two types. Vegetative matter and non-vegetative matter. Vegetative matter is nothing but vegetables or fruits, seeds or wooden substances that basically have a tendency to swell up later, and they are more harmful because when they are inserted inside, they are small in size and later on they swell up and cause difficulties. It is difficult to remove them, and they also completely occlude the canal. So here we have seeds and wooden substances. Small wooden pieces are usually kept, and sometimes some other fruit or vegetable related substances are also placed inside the ear. Small substances. Non-vegetative substances include anything like stones, small gravel pieces, or some beads, or some plastic toys with which they play. Or as I said, in case of adults, it could be broken pieces of matchsticks, or leftover cotton swabs. Sometimes we use a cotton swab that is very, very small, and then that can get impacted inside and difficult to be removed. Or some metal pieces. This can happen in adults or children, can randomly go and get impacted. These are all the non-living substances. Or some pieces of paper can also occur. Living substances are flies, insects such as mosquitoes, and another important thing is maggots. All these substances are foreign bodies in the external auditory canal in children as well as adults, but this is usually a condition involving pediatric patients. Now, living foreign bodies have been put under a special section because they have to be treated in a slightly different fashion. Let us learn, and they also produce some special clinical features. These non-living substances, they go inside and they are there stably like that. But living objects such as flies, when they go, they are still moving, and this causes intense irritation to the patient. And they immediately come. Non-living substances can sometimes be there inside for a long time, but living substances, when they go inside, they immediately come under the notice of the patient, and the patient is brought to the hospital. So let us look into the treatment of a foreign substance inside the external auditory canal. Just like how we remove wax, even these substances can be removed. If at all they are small in size, syringing can be done for small objects and for seeds. Suctioning can also be done. Microscopic removal can be done if it is a complicated substance, something like a metal piece or a slippery substance, or even plastic or folds of paper. If it is difficult to be manipulated by suctioning or syringing, microscopic removal can be done. And in rare cases, if it is, we have learned this in the anatomy of external auditory canal, that there is a narrowing called isthmus about 6 centimeters from the tympanic membrane, which is a junction beyond which, if something gets impacted, it is difficult to be removed. So sometimes, rarely, what happens is a foreign body gets impacted beyond the isthmus, and if all these methods fail, then a post-oral approach has to be done. You have to enter into the middle ear through perforation or go into the deep meatus and finally remove that substance. So it can sometimes become quite dangerous. Foreign body can become quite dangerous. So treatment options that we have: first, for simple small objects, syringing, suctioning, and then for slightly difficult ones, we can do a microscopic removal with special instruments. And lastly, post-oral approach. If it is impacted beyond the isthmus, medial to the isthmus, if it is in the deep meatus, or sometimes if the object is sharp, it can actually perforate the tympanic membrane and even get impacted at the junction, or sometimes it can even go into the middle ear. In all those cases, a post-oral surgical approach is done. Now, if it is a living thing that has entered inside, then first thumb rule to be followed is never try to remove it in the live state. First, kill the insect and only then think of removing, because it is practically almost impossible to remove a live fly or insect that is sitting inside. So, how do we kill? By putting some oil. That's a home remedy that has been followed by ages. In the hospital setting, we can use spirit or chloroform water. So the first rule is never try to catch it alive. All these substances will kill the insect or a fly or whatever that has entered. Because these, even sometimes small cockroaches, they all are crawling, flying, and they are causing intense irritation and pain to the patient. So first try to kill them, and by instilling any of these substances, and then they can be extracted out quite simply and smoothly, either by any of the above mentioned processes: syringing, suctioning with the help of a hook, or any other instrument can be used. Now there is another thing that requires a special mention, and that is maggots. Maggots are flies that get attracted to foul smell, and not just going inside the external auditory canal, they go and live there, and they even lay eggs, and those eggs will hatch out into larvae and form maggots. Those larvae are maggots. So these maggots will cause severe pain and swelling around the ear, and it is a very foul smelling condition. So the patient has three problems here. One is there is severe pain. Next, there is swelling, and it is foul smelling. And this foul smell will further attract maggots. Along with swelling, there is blood-stained discharge. Blood-stained, foul-smelling discharge occurs, and it can also cause perforation of tympanic membrane later on. If timely attention is not given, it can also perforate the tympanic membrane. So how do we treat this? How do we treat maggots? As with any other living object, first kill the maggot and then remove them with forceps. Chloroform drops can be used. Drops to kill maggots, and then remove with forceps. This is about maggots, and with this we complete the topic of foreign body in the ear. It's a very simple and straightforward topic. Foreign bodies are of two types, living and non-living. The major distinction is if it is a living object, please understand that the patient will have lots of irritation and pain, and before they are removed, they have to be killed. If it's a non-living object, if it is vegetative, give it special attention because these substances later on swell and make things difficult. If it is non-vegetative also, it has to be removed, but vegetative substances are more dangerous than non-vegetative substances. So you can treat them by syringing, suctioning or microscopic removal. If it has gone very deeply beyond the isthmus or into the middle ear also, then a post-oral surgical approach is required. Living objects, special mention about maggots. Because maggots is more dangerous than a small fly or mosquito entering, because they stay there and they lay eggs, and those eggs hatch out into maggots and they cause blood-stained discharge. They can even perforate tympanic membrane. The clinical course is quite complicated, so maggots require special attention. Now the next clinical condition is next one in the list of miscellaneous conditions. The last one, in fact, is Keratosis Obturans. Now please understand that generally the name of any condition gives you a hint about what it is. And if it doesn't give you a hint, that is an important question in the exam. Because you cannot guess anything, you cannot think anything, and you will leave the question. So it is mandatory that you study about it. And for more reasons than this, Keratosis Obturans is an important topic. So please pay attention and listen to it. It is a firm mass. What is Keratosis Obturans? It is a firm mass. Mass made up of what? Desquamated keratinized epithelium and cholesterol, where in the external auditory canal. Sometimes it looks like a cholesteatoma. Cholesteatoma is a condition of middle ear, but this looks like a cholesteatoma in the external auditory canal. So we also call it cholesteatoma. That's another name for Keratosis Obturans. Cholesteatoma in external auditory canal. It's very much different from the cholesteatoma in middle ear. Okay. So let me write it down for you. It is a firm mass composed of desquamated, keratinized epithelium, also known as cholesteatoma of external auditory canal, because it resembles cholesteatoma. And this is associated with osteitis. It is a condition involving the temporal bone of external auditory canal, osteitis. Granulation tissue formation, of the deep bony meatus, and this firm mass that is present in the external auditory canal is so hard it actually exerts pressure. It causes pressure effect which causes resorption of the bone. It is so hard and firm that it actually exerts pressure, and that too pressure on the bone, and leading to resorption of the bone, and when the bone is resorbed, it leads to widening of the meatus. And sometimes there is so much resorption of the bone that the facial nerve that is traversing in that area gets exposed to the external environment, and then it gets paralyzed. So keratosis obturans can lead to facial nerve paralysis finally. What is happening? It can exert pressure. Pressure is exerted on the deep bony meatus, leading to resorption of bone. And this resorption of bone leads to widening of external auditory canal, so much so that the facial nerve traversing through that area is exposed. And that will lead to facial nerve palsy. But please remember that it does not cause osteonecrosis. It does not cause osteonecrosis. Pressure effect is different and osteonecrosis is different. It will cause resorption of bone and widening. Keratosis obturans causes resorption and widening of the bone of the canal because of resorption of bone, but not osteonecrosis. So anyways, why does all this happen? It can happen in 1 year, or sometimes it can happen in both years also. Exact etiology is not known, but we know that it is associated with bronchiectasis and sinusitis. Bronchiectasis and chronic sinusitis. So the basic physiology, what's happening here, let us understand. In normal individuals, as I have told you in the composition of cerumen also, the desquamated epithelium from tympanic membrane and bony meatus keeps on shedding, and that traverses, it migrates along the posterior meatal wall and comes to the surface and it is expelled. Somewhere in this process, something is not happening. So failure of migration of this desquamated epithelium will lead to its accumulation and will finally form a ball of firm mass, which is called as keratosis obturans. This is the basic pathophysiology of why keratosis obturans is occurring. Now that can get obstructed, the migration can be failed because of wax impaction there or some foreign body impaction there, and that is leading to accumulation of this epithelial plug. That is a possibility. So, what you have to understand in the pathophysiology is there is failure of migration of desquamated epithelium from tympanic membrane and deep bony meatus. Why is there failure of migration? Due to wax or foreign body impaction that is causing an obstruction to this migration. Failure of migration of desquamated epithelium from the tympanic membrane and deep bony meatus due to wax or foreign body impaction leading to obstruction of this migration. So what happens because of this accumulation? What happens because of keratosis obturans? One, we have learnt the final most dreaded possibility is it can cause resorption of the bone and lead to facial nerve paralysis. But before that, let us see the clinical features. The patient will experience pain, otalgia will be there. Because of all this impaction, obviously the sound pathway is disturbed, and that leads to conductive loss of hearing. Yes, nothing happens to the tympanic membrane. Tympanic membrane, middle ear, all that is fine. It's only the external ear this is seen. And finally, as we have learnt, a bone resorption can occur, but even before that, tinnitus can occur, granulation tissue can be present, let me show a picture of how keratosis obturans looks like. Let me show a picture of how keratosis obturans looks like. This is how it looks. This is all the accumulated desquamated epithelium, and it is occluding the external auditory canal, obscuring our view also. We cannot even see, look at the tympanic membrane. All that we see is a blackish white mass. And then it can also cause discharge from the ear. These are the clinical features. And what is the treatment? And the treatment of this condition is, obviously when it is a mass that is occluding and causing so many problems, we try to remove it. Removal is the treatment. But before removing, keratolytic agents have to be used. Keratolytic agents such as 2% salicylic acid, they will cause breakdown of this mass. That will help in removal. 2% salicylic acid in alcohol is used to soften this entire mass, and then it can be removed by suctioning or syringing, or any other instrumentation. This is the treatment, and sometimes even anesthesia is needed to remove this mass. And if it is deep, we can use microscopic method to remove the debris, remove the mass. And prophylactically, before removing it, cleaning should be done. And also when we understand that the keratosis obturans, the mass is present, we should try our best to prevent inflammation, infection, and the rest sequelae of it. So this is about keratosis obturans. It's quite a simple condition. Basically, normally what happens is migration of the desquamated epithelium occurs, and failure of this migration will lead to its accumulation, and it will form a firm mass that is composed of desquamated keratinized epithelium, and it is associated with osteitis and granulation tissue formation in the deep bony meatus. Exact etiology is not known, but it is associated with bronchiectasis and chronic sinusitis. And this mass can exert pressure on the bone and lead to bone resorption and facial nerve exposure, leading to facial nerve paralysis. Clinical features: the patient will have pain, conductive loss of hearing, tinnitus, and granulation tissue formation, and discharge is also possible. This is how keratosis obturans looks like upon examination. And treatment is by first using keratolytic agents and then removal of the mass. So these are the three miscellaneous conditions of the external auditory canal. First is impacted wax, second is foreign body, and third is keratosis obturans, out of all which keratosis obturans is important from examination point of view, and impacted wax and foreign body are important from a clinical point of view. Thank you very much.